Okay, yeah, thank you, Vivek. I'm very happy to be here to talk about this topic. And getting back to the title, um, I think that you need some explanation. So I actually gave a Department of Medicine talk at the end of February that Liz Tam appropriately titled The Crown. So this is kind of a follow-up, and definitely the coronavirus is evolving. So my goals and objectives for today are to discuss the origin and transmission of COVID-19, to talk to you as requested about the clinical presentation of COVID, and to briefly compare it to influenza, MERS, and SARS, to very briefly review the treatment options. Actually, Dr. Dominic Chow and Scott Souza gave an incredible presentation yesterday on this, and I've actually borrowed some of their slides. And then to discuss the basic infection control and prevention strategies for COVID-19, both for the hospital as well as for people in the community. So this is a dramatic slide, and this is really why we're all here today. And this is from the Johns Hopkins website. So they do an incredible job of daily updating this. So this is information as of 3/24/20, and things literally change by the day. So you can see the total confirmed cases so far, 414,277, the total deaths, and see if I can get rid of that, and the total recovered. And you can see the globe. This is something that's now a pandemic, and we'll go into that a little bit later. And then also this nice graph at the bottom that's updated daily. And this is really the basic epicurve of the coronavirus. And for you all in tropical medicine, you're probably better virologists than I am, but I'm just gonna briefly review this. So if you look at this EM picture of the virus, you can see why it has its name. So corona, of course, means crown, and that's because of these appendages on the surface of the virus. But it's a member of the nidovirus family. It's a medium-sized, enveloped, positive stranded RNA virus, and it causes a range of disease in animals as well as in humans. And here's a more diagrammatic picture of that, but these proteins on the outer coat have importance when we talk about therapeutics. So in terms of basic RNA viral structure, it's not that remarkable. But again, these specific structures are targets for therapeutics. Okay, and I really like this slide because this shows the coronavirus phylogenetic tree. And you can see there are multiple branches. You can see the MERS-CoV virus here, the SARS virus, okay, and all of these other animal viruses. So the current SARS-2 virus is in this green leaf here with the SARS-1 virus. Okay, and here is another, I guess, relationship slide that shows the Wuhan COVID-19 virus and its relationships to the other SARS viruses. And note in particular these bat viruses, because this is where it's the animal, this is really the animal that the coronavirus probably ultimately came from. What's also remarkable on this slide is that they were able to actually detect or genome sequenced this virus on January 13th, 2020, after this virus was described for the first time in December of 2019. And the complete genome sequence was actually posted on the web by January 13th. So just some remarkable strides in genome sequencing. So coronaviruses are worldwide, they're ubiquitous, and they typically circulate in the winter in temperate climates. They cause up to 10% of acute respiratory infections in adults. So this is one of the causes of the common cold. It's also an important source of viral otitis media, acute otitis media in children. And children seem to be relatively asymptomatic and have mild forms of coronavirus infection in general compared to adults. And occasionally it can cause diarrhea in infants, and it's been noted in children who are hospitalized with diarrhea, but it's primarily a respiratory virus. The more severe manifestations occur in adults, in patients with acute exacerbations of COPD. It can cause influenza-like illnesses, acute exacerbations of bronchitis, pneumonia, and I think most people remember SARS, or the severe acute respiratory distress syndrome that circulated in 2003, which caused very severe acute respiratory pneumonia, ARDS. Then 9 years later, we had MERS, or the Middle Eastern Respiratory Distress Syndrome, which is a little bit less severe. And of course, now we're dealing with the novel coronavirus 2019. So this slide shows the tendency of these coronaviruses to cross species. So the SARS virus, we now know, probably came to humans via bats, then into masked civets. So these civets are sold for food in live animal markets in China. And the genetic analysis now suggests that this occurred probably in late 2002. So MERS is interesting. So again, many of you here may remember this camel story. So MERS is thought to actually start in dromedary camels. And interesting, the serologic evidence suggests that this actually happened at least 30 years ago. So these coronaviruses ultimately are zoonotically transmitted to humans. Once it gets into humans, there's person-to-person transmission. Okay, so coronavirus 2019, we're still not quite sure, but we think it may be bats to snakes. And I have to tell you honestly, before COVID-19, I did not know what this animal was. But this is a pangolin. It's an endangered species, and in China is also a delicacy used for food. But humans are the ultimate recipients of the COVID-19 virus, and humans are the most symptomatic. So the virus may pass through all these other animals relatively asymptomatic. Okay, so in January 2020, WHO declared the novel 2019 coronavirus a global health emergency. And it was identified as a new virus the month before. By that time, 8,000 people in mainland China were infected, and 171 people were dead. It clearly originated in the city of Wuhan in the province of Hubei, and the early cases were associated with the Hunan seafood market. And travelers who departed Wuhan that resulted in global spread. So it's important to know that Wuhan is really a commerce center in China. And this slide depicts the railway networks, these very complicated railway networks that all go through the hub of Wuhan. Okay, so the earliest cases of COVID 2019 could be traced directly back using genomic analysis to a Hunan seafood market. Okay, and if you've been to China and been through any of these seafood markets, you have vivid memories of what these places are like. So they have, again, food from slaughtered animals, but they actually have live animals. Okay, and here you can see a bat, a koala bear, and this sign is circled because I don't read Chinese. I don't know, I admit I don't know any Chinese, but they knocked off one of the, or they blacked out one of the characters, which after this market was closed to selling live animals. And this is just another graphic picture of the animals, and you can see their menu of what is available. So in the United States, I guess we typically don't think about a lot of these animals as for food. But in China, you can see the clear array of domestic and wild animals that are consumed. Okay, and then this picture, I think, really says it all. So it's not just in these live seafood markets, but it's really in the course of daily life and smaller venues also. And you can see the mingling in this picture of people. You can see their domestic pets. You can see the slaughtered meat for sale, and again, a carcass of a, I can't tell really what kind of animal that is, but it could either be a domesticated or wild animal. So it's this mingling in one space of all these animals and humans that allows for the direct transmission of these typical animal virus into humans. Okay, and here's bat soup. So in February 2020, the White House declared COVID-19 a national public health emergency. And American citizens in the Hubei province, in the 2 weeks prior to their re-entry into the United States, were then required to undergo 14 days of mandatory quarantine upon returning to the United States. And then those returning from anywhere in mainland China had to undergo screening upon entry and have a monitored self-quarantine. And there was a prohibition of foreign nationals other than immediate family members of US citizens and permanent residents who were in China for the past 2 weeks. So they were directly banned entry into the United States. Okay, then by March 11th, 2020, WHO actually declared this a pandemic. So I think it's important to understand the concept of a pandemic. So this is the, if you use time zero as the introduction of the hypothetical generic virus, because nobody has immunity in the population at that time, you see the spike in disease incidence. Okay, so this slide I actually took from an influenza talk, but this is applicable to really any new virus or new strain of virus that enters into a population or community. So as the cases decline, Okay, you get to epidemic range, and then ultimately you get to an endemic rate, which may actually be zero at some point in time. So the green wiggle here is the mean level of population antibodies. So the population begins to develop some immunity over time, okay, to this first pandemic virus. But then again, we have a new introduction of a new virus because, and again, nobody has immunity to this virus or this strain of virus. So again, we have a spike in cases. It drops down as time passes, and then people start developing antibodies to this virus. So again, clearly right now we're in a pandemic phase. And depending on the organism, there may be large differences in the interpandemic period. For instance, influenza, the H1N1 pandemic of 2019 was preceded by the pandemic of 1918. So there was quite a different large span in time for the influenza virus. Okay, then this is another slide from my previous talk. So I use this to show the rapid spread of this disease. So on January 29th, 2020, this is what the map looked like of countries reporting cases. Okay, but 2 days later, this is what the map looked like. So a dramatic, I'm going to go back again. So we went from here to here in a matter of 2 days. In the United States, we're seeing a similar pattern. So going back to February 3rd, there was 1, 2, 3, 4, 5 states with confirmed COVID cases. Okay, but this is where we are in the 3rd week of March. And you can see pretty much everybody has had a case. Some of the US territories have been spared, but pretty much every state in the United States has a case. And you can see Hawaii in the 51 to 100 case range right now. Okay, the transmission of the novel 2019 coronavirus is important to understand. So once it got from animals into humans, the transmission between humans, person to person, is how this pandemic exploded. So the virus is transmitted by respiratory droplets from coughing, sneezing, or talking. We know that there's been clusters among healthcare workers and family transmission, presumably from close contact with infected persons. And we also know that the virus can survive on various surfaces. So contact with a contaminated surface, if you touch that surface with your hand, then touch your face, your nose, your mouth, or other mucous membrane surface, that is probably another significant route of transmission. We also know that asymptomatic transmission occurs, but we're not sure yet how important that is in transmission compared to person-to-person transmission. And more about that now. But one important thing to stress about this virus in general is we lack detailed knowledge about the epidemiology of this virus. And this was a recent letter to the editor in the New England Journal. So this letter compared the aerosol and surface stability of the SARS-CoV-2 or COVID virus with the original SARS virus. I'm going to take you through this slide because I think it's very interesting. So the SARS-CoV-2 is the red or the pinkish looking, and the SARS-CoV-1 is the blue. So these are titers of viable bigger laser pointer. Okay, so these are titers of viable virus in aerosols. So you can see that the SARS-CoV-1 virus survives better, so there's a higher titer than the SARS-CoV-2, but at 3 hours, okay, there is some detectable virus of detectable amount of both viruses. And then they looked at the titers of viable virus on copper, cardboard, stainless steel, and plastic. So you can see, again, the comparison of the blue and pink, but also the steepness of the curve in terms of death of virus. So the virus actually seems like it survives better on plastic and stainless steel. And then another way to look at this is the predicted decay of virus titers. So copper, again, it drops fairly rapidly. But for plastic and stainless steel, you can see that the curves are way less steep. So this virus is able to survive on inert surfaces. And there's been stuff going around on the internet about comparing the survival of the virus on money, dollar bills, cloth. Haven't really seen actual studies on that. But this is important for cleaning and disinfection. Okay, then I'm going to shift gears a little bit to talk about the clinical manifestations. So when this virus was first reported, these are really the 3 hallmark symptoms: fever, cough, and shortness of breath. And these were primarily markers of lower respiratory illness. So when this virus was first reported, I think a lot of people thought that this was way less of an upper respiratory infection, and it was more of a lower respiratory infection. And these symptoms were, or this symptom triad, was thought to be helpful in distinguishing the coronavirus from influenza, which is also circulating during the same time period. Okay, and this is to show you the typical symptoms. So this was the first case in the United States. This was a traveler who had returned from Wuhan. So I just show you this to show you the time course for these symptoms. And this was someone who actually got sick enough to be hospitalized. So you see the cough as the first symptom, followed by subjective fevers, and the maximum temperature was as high as 39.4, so fairly high fevers. The cough lasted for a long time. He did have rhinorrhea, but interestingly, it was not near the onset of symptoms. It came fairly late in the disease course. The patient had fatigue, which is nonspecific, and this person also had gastrointestinal symptoms. So not just respiratory symptoms, but actual nausea, vomiting, and diarrhea. And this was his X-ray. So it may not reproduce that well, but what he had was bilateral interstitial infiltrates. There's some streakiness, increased streakiness in the lower lung fields as well. But this looks really indistinguishable from any other atypical pneumonia that could be caused by viruses, mycoplasma, chlamydia, etc. So the clinical manifestations, the incubation period is between 2 to 14 days. The average is really falling between 5 to 6 days in most cases. And hot off the press are the symptoms of anosmia and dysgeusia. So loss of smell or altered smell and altered taste are now being reported as early symptoms of COVID that might be appropriate triggers for testing even before respiratory symptoms. So even before they have any upper or lower respiratory symptoms, they may start experiencing loss of taste or altered taste or loss of smell. So most of our data on the clinical manifestations comes from hospitalized patients in China, because these are the ones that were reported early on. So fever is extremely common. It can be prolonged and it can be intermittent. A cough is also very common, up to 80%. And then myalgia or fatigue were lumped together in this study, and then shortness of breath in up to a third. But remember, these are mainly from studies of hospitalized patients. The less common clinical manifestations that are now coming to light as we become aware of people with milder disease, as testing has become more widespread. So sore throat, headache. So again, this may well be indistinguishable from somebody with influenza or a non-specific viral illness. Early on, the cough was described as dry, but now we know that occasionally people can have a productive cough, but it's usually with mucoid and not purulent sputum. Hemoptysis has also been reported, and we've also talked about these GI symptoms in that first patient, but we've also found that they may develop prior to fever and respiratory symptoms. So this is from an article in Lancet. These are cases out of China to show you that every age group is affected, but these are also shows where people were admitted to. So in the younger age groups, most people ended up being managed on the general wards. But as you can see, in the older people, a much larger percentage were admitted to the ICU. Okay, and this is from the same series of 41 patients, looking at those who ended up in the ICU versus those who did not end up in the ICU. So the complications that have been reported, acute respiratory distress syndrome, viremia is reported, and then what look like other multi-organ involvement other than the respiratory tract. So there's now some evidence for a direct viral effect on the heart, possibly on the kidney. And this is also interesting. So fairly low rates of secondary infection compared to influenza viral patients. And then again, shock, sepsis is a complication of these patients. Okay, and the same series, this is how patients were treated. And we'll talk about these therapies later on, but you can see people got antiviral therapy, they got antibiotics, steroids were used, people ended up on dialysis, and an array of respiratory support was required for people ranging from mild hypoxia to people who had severe ARDS and required mechanical ventilation and ECMO for treatment. And this is the outcome. Again, these are the same groupings, all patients, ICU patients, and non-ICU patients. So in the ICU patients, you can see that the death rate was 38%, so fairly high, but this is a relatively small series. So the case fatality rate is clearly age-related. So this was, you can see the case fatality rate for people over the age of 60. So it essentially doubles with each decade. So among the 60 to 69-year-olds, 3.6%. In the 70 to 79-year-olds, 8%, and almost a 15% mortality in those over the age of 80. For people with cardiovascular disease, diabetes, chronic lung disease, hypertension, and cancer, they also had a higher case fatality rate. And for the patients who ended up in the ICU, who had respiratory failure, requiring mechanical ventilation, septic shock, or had multi-organ dysfunction, the case fatality rate was almost 50%. Okay, then I'm going to shift gears a little bit now. So the virus has been isolated from the nasopharynx, the oropharynx, blood, urine, and stool. And the nasopharynx and oropharyngeal swab are positive fairly early on. They're positive before the stool turns positive. So definitely respiratory secretions are felt to be infectious, but at this point in time, there's no evidence of significant transmission by stool or the fecal-oral route. Okay, and then who should be tested? So right now, not everybody should be tested. And the reason for that is that we don't have a wealth of testing materials. So in Hawaii, we're actually coming very late to the game in terms of getting access to the tests. So it's simply until about 2.5, 3 weeks ago was just not available in the state other than through the Department of Health. And a lot of clinicians, I think, were very frustrated by that, but basically that's all we had. But now we have access, we have greater access, we have shorter turnaround times, but we don't have unlimited testing capacity. So many people have put out guidance or guidelines on who should be tested. And this is the current testing guideline for the Queen's Health System. So we require that people have a fever or signs and symptoms, so either cough or shortness of breath, and we've recently put in beyond baseline, and they have to have one of the following other risk factors. So exposure, so having close contact with a confirmed COVID patient within 14 days, and we're going to talk more about close contact and what that means. Travel outside the state now in the last 14 days prior to symptom onset. And this travel risk factor has been constantly evolving, ranging from the level 3 CDC high-risk countries to really the point where there's many states in the United States that have large numbers of patients. So for us, this is constantly evolving, and our criteria now is being outside the state in the last 14 days. So occupations that place people at high risk, so flight attendants, hotel workers, cruise ship people. We've actually put in first responders and bus drivers, and of course, healthcare workers. And then those with comorbidities who have a poorer prognosis and higher case fatality rate, who have more severe disease are also candidates for testing. And then anybody in the hospital, even if they don't have other specific risk factors, if they have fever, signs of shortness of breath, cough, which cannot be otherwise explained, are candidates for testing. When you compare our criteria to, say, LA County Public Health Department, they are also looking closely at nursing home residents, long-term care facilities, because of their demographic of who is getting the disease. So defining a close contact. So the CDC defines a close contact as being within 6 feet or 2 meters or within the room or care area of a COVID-19 patient for a prolonged period of time if you're not wearing recommended personal protective equipment or PPE, or if you're a close contact that is caring for, living with, or visiting, or sharing a healthcare waiting area or room with a confirmed COVID case, or having direct contact with infectious secretions of a COVID patient while not wearing the recommended personal protective equipment. Okay, so close contacts, again, are clearly defined, but we also know that asymptomatic persons can transmit the virus. And I think this is the biggest source of fear and anxiety and panic and paranoia that is going on in the community, that you could be exposed to someone who has no symptoms, yet can transmit the virus to you. So this is probably the classic article that appeared in the New England Journal of Medicine. This was a German citizen who had attended a business meeting and flown to China. So this is the index patient here. Okay, he visits Germany and goes to a business meeting. Okay, then he flies to China and starts to develop symptoms and then tests positive here. So there are other people who attend the business meeting, okay, and then they subsequently develop symptoms. So patients 3 and 4 are the ones who actually have contact with the index patient, okay, and then they test positive and have symptoms, okay, but it's these asymptomatic contacts, okay, who all eventually develop symptoms and test positive. Okay, and we'll talk about the approach to these asymptomatic patients when we talk about the Singapore and Hong Kong experience, because although this has been documented, asymptomatic patients are probably way less important in actual transmission than people who have florid symptoms. Okay, then I'm just going to show, this is one of Dominic's slides, and Scott Scusa's slides from yesterday, just showing you that there are various therapeutic targets on the virus and the host, and testing of an array of compounds is now going on. The receptor is probably the ACE2. ACE2 is definitely one of the important receptors. So blocking this ACE2 receptor with some of our commonly available drugs, our antihypertensives like the ACE inhibitors and ARBs, for instance, may be part of the therapeutic approach. And then, of course, targeting parts of the virus itself. So I'm not going to say much about this because, again, I refer you to Scott Souza's and Dominic's lecture from yesterday, which is posted on the Department of Medicine website. So the treatment is basically supportive care. So at this point in time, we